I wanted to discuss a paper that really made a big splash a week or so ago. It was on the long-term cardiovascular complications of COVID. I thought I'd go in and discuss some of the issues with that paper, and more so, every paper has limitations, but more so some of the conclusions that were being drawn from this paper. The paper is from a group that's led by Dr. Ziad Ali. Dr. Ali is a nephrologist who seems to have dedicated himself to something that's been come to be known as long COVID. He describes in a tweet that, and you can go on his timeline and take a look. He clearly is a big proponent of how significant of a threat long COVID, which has come to mean persistent symptoms well after you've recovered from COVID. And so in a tweet of his recently that he was, when he was putting out his paper that was published in Nature, he said that millions of lives around the world depend on us making progress on long COVID. We need a concerted effort to better understand and treat long COVID. We need a long COVID moonshot. We can and must do better. And then he tweeted his paper. So clearly, moonshots require lots of money. so there's clearly a call to, fund more research on the matter. And him being one of the lead researchers, I guess he'd stand to gain a fair amount if the world decided that this is something that needs to be funded in a significant way and needs to be researched in a significant way. Now, so obviously, I point this out because he's written a number of papers in this space. He's one of the folks that generates evidence to say that long COVID is real. So he has a bias. But there's nothing wrong with strong biases in research. So I get a little uncomfortable when folks start talking about pharmaceutical companies and their biases, because it's, of course, everyone has biases. And while it's important to know and understand biases, it's also important to take a look at the research itself and try to fit it into some context, independent of what the individual researcher's biases are. I say that because some of the best research in history has come from scientists who believed long before there was evidence to live up to the faith, if you will. So that's why I find it more interesting to ponder on what leads one to a strong pre-existing bias. Also, in terms of trying to decide, all right, is this a bias what is the bias based on? Is this a bias that should lead to some deep insights that make you understand something more than what everyone else, who doesn't have that deep expertise can understand, or not? Just as an example, Thomas Starzl strongly believed in hepatic transplantation. He was one of the, of course, and this was at a time when people thought it was actually unethical to do these things and do transplant. And of course, the initial series of transplantation, the initial history of transplantation is marked by just abject failure. Just terrible stuff. But Tom Starzl also happened to be one of the foremost surgeons of his time. He wasn't just some guy that slept at a Holiday Inn the night before and was like, I think liver transplantation is what we should be doing for people with failing livers. Alfred Blalock, who under the direction of the great Vivian Thomas, fantastic story in and of itself. He took a blue baby, took blue babies that were born blue and cyanotic, destined for a very short lifetime. Alfred Blalock, again under the direction of Vivian Thomas, took a blue baby to the operating room to reroute the infant's hypoxemic blood to the lungs and try to extend the life of these poor babies. And again, this was well before there's any real research in the field. But this was Vivian Thomas had spent months rescuing a cyanotic dog model before even attempting this in an infant for the first time. So, these are sort of obviously Blalock, Thomas, Starzl. These folks have very, very strong biases, but these are strong. I would argue these are strong priors, pre-existing. There are very strong pre-existing beliefs to bet on because of the deep kind of content expertise that these folks have. This is altogether, I think, quite different than the biases of many researchers who build their priors on trying to manufacture needles and haystacks of data. Trying to find a signal out of the noise of millions of data points that come from large administrative databases is just not an easy task. And then, so when you add to that, when your fundamental bias is when your ability to acquire funds for research is contingent on finding an important signal in the massive data, there's always a path to fashion to find a signal. So in this study, this Nature study, the authors used the U.S. Department of Veterans Affairs national healthcare databases to build a cohort of 153,760 U.S. veterans who survived the first 30 days of COVID-19. And then they had two control groups, a contemporary cohort consisting of about 5.6 million users of the Veteran Health Association, who had no evidence of SARS-CoV-2 infection. And then they used a historical cohort. So this is predating the COVID pandemic, consisting of about 5.8 million non-COVID infected veterans health users since during 2017. So these cohorts were followed, each one of these three cohorts were followed longitudinally to estimate the risks and 12-month burden of pre-specified incident cardiovascular outcomes in the overall cohort. And this was done according to the setting of the acute infection. Were they non-hospitalized? Were they hospitalized? Were they admitted to intensive care? So all three cohorts, the folks that had COVID, the contemporary cohort that tested negative for COVID, and then the historical cohort, they were all followed longitudinally for a year to see what cardiovascular outcomes they had, what the incidence was. And again, the settings that they looked at, they broke down into three: non-hospitalized, hospitalized, and critically ill patients. So the question being asked here is, or they're attempting to ask is, does SARS-CoV-2 result in downstream cardiovascular complications? The authors attempted to assess cardiovascular disease in those with SARS-CoV-2, but to know if these rates are higher than normal, a control group is needed. And in this case, as I've said, the control group is a contemporary cohort that are test negative and a historical control. Yeah, here's the key figure that's been shared more than a few times. And the figure shows that compared to the control group, the contemporary control group in this case, the rates of a number of different disorders is significantly increased. And the rates of increase is highest in the ICU setting, next highest in the hospitalized setting, and then lowest in the mild non-hospitalized setting, but still higher than the contemporary control group. The obvious limitation is one that I've harped on over and over again for a number of different analyses, is that it is 100% probable that those without COVID here includes a number of people who actually had COVID, because this is just folks that test positive for COVID. And as I've said in the past on other videos, that if you happen to test positive outside of this electronic health system in the VA, you would not be captured in this group. You would, even though you were test positive, you would be put into the test negative bucket here, right? If you simply had a very mild case and chose not to get tested, right? And this is a veterans health study, primarily elderly men who, from elderly veteran men who, from my experience, are relatively stoic. If you had mild symptoms, this is not the group that is running around looking to get tested, right? So it no doubt has a number of people that are in the test negative group that they're calling, Dr. Ali's group is calling, they don't have COVID, but they actually, did have COVID. And this obviously applies much more to the group with mild COVID, and in that specific, bracketing would bias the result to the null. So the mild group in this case is very, very small if you look at the chart in terms of the difference between contemporary control and positive control. And I think there's little doubt in my mind that would be clearly a null finding if you were able to figure out who actually did and didn't have COVID. This applies a lot less to the hospitalized and the ICU group, because everyone who gets hospitalized, everyone that gets to the ICU pretty much is getting tested. The other bias that's very important, that the authors think they've corrected for, but I still think is problematic, relates to the fact that the people that are diagnosed with COVID get a lot more diagnostic tests. So once you're brought to the attention of the health system, you also suddenly have a lot more diagnoses added to your record. And this is in part kind of a recent phenomenon. The last decade has seen payments from payers, from the people that pay for healthcare, tied to how ill patients are. So A great example is Medicare Advantage, right? Medicare Advantage is a scheme to move patients from traditional Medicare fee-for-service, where the government simply pays your doctor, your hospital for you because you're a Medicare patient, right? And because hospitals, providers, etc., because they're having trouble controlling costs, the government said, you know what? Let's move a group of patients who are in traditional Medicare and move them to be managed by a private company. That private company now, when a cardiologist goes to, say, order a stress test and somebody that has a Medicare Advantage plan, the Medicare Advantage plan now says, no, you can only get a stress test for this so indication, or whatever. Whereas traditional Medicare, didn't have those bars. Just giving you one example of why this happened. But here's the thing: Medicare pays these private companies per patient that they manage, and they don't just pay the same amount for each patient because some patients are much sicker than other patients, right? So what they do is they pay the Medicare Advantage plan a rate that's based on how sick the patients are. Well, how do you figure out how sick the patients are? That has everything to do with the health system and the number of diagnosis codes that's attached to the patient. So it's a huge issue, and it's been seen over and over again in multiple different analyses that once you go from traditional Medicare to Medicare Advantage, because of this kind of incentivized scheme to pay more based on how sick you are, the number of diagnoses massively jump when you go from traditional Medicare to Medicare Advantage. So there's a nice chart, and this is called Upcoding. There's a very nice chart that shows that if you're in traditional Medicare and you go from age 64 to age 65, the number of diagnoses you have don't really change that much if you're for traditional Medicare. But if you're 64 and then when you turn 65 and you have now joined a Medicare Advantage plan, your number of diagnoses jumps a fair amount. There's actually classes that Medicare Advantage plans hold for doctors to try to make sure that they'll attach more diagnosis codes. So this is definitely something real that happens a fair amount. So it's clear that using diagnosis codes, certainly in the last decade, as a surrogate for illness is really, really, really a kind of a whiffy position to have. So if you're going to have a big problem with the VAERS database in terms of not verifying whether or not these adverse events truly are related to the vaccine or not, because they're not validated and they aren't checked, right? The VAERS database is good for picking up signals, but then you have to kind of go into the chart and take a look and see, is this real or not? The same thing has to apply, I think, for any databases, any research that involves using claims data, ICD-10, these diagnostic codes, as a surrogate for actual disease. The other thing, of course, that happens is that, in addition to this issue of coding, the other thing that happens is that imaging and testing happens a heck of a lot more if you go into the system, right? So you'll end up diagnosing a lot more, say, pulmonary nodules in patients who are admitted to hospitals, because patients who are admitted to hospitals get CAT scans of their chest a lot more than somebody who's not admitted to the hospital, right? How do we know? But of course, that pulmonary nodule may, there's tons of folks that walk around with what's called incidentalomas, meaning pulmonary nodules that you never hear about and you'll live to 120 with. But you enter a hospital system, now suddenly you get a CT, you get a pulmonary nodule, and you're like, we found a pulmonary nodule, and you get a CAT scan in a year, the pulmonary nodule is the same, and hopefully you never think about it again. But now, because you came into contact with the healthcare system, now you have a diagnosis of a pulmonary nodule. So the question is, okay, how does one deal with that particular confounder? So what I'm describing and this is the problem with all observational retrospective data sets, is various confounders that will limit your ability to actually make comparisons then make conclusions. So this is another big confounder. And I think the authors of this Nature study would point to their use of negative controls to limit this particular confounder. Basically, the authors evaluate other diagnoses that aren't related to what's going on, to see if these diagnoses occurred more. The diagnoses studied are shown here. They used hypertrichosis, melanoma in situ, sickle cell trait, perforation of the tympanic membrane, malignant neoplasm, lung, B-cell lymphoma, and Hodgkin's lymphoma. Those are the negative controls used. And when they looked at those ICD-10 codes, they did not find that those particular ICD-10 codes increased compared to contemporary controls. And so they would say, aha, so, we are taking care of the confounder of, testing more and catching more diagnoses. But unfortunately, these negative controls picked aren't ones we would expect to be coded more based on, say, something like more imaging that happens after a COVID diagnosis is made. If you test positive for COVID, you're more likely to have your vitals checked. You're more likely to have a CAT scan of your chest. You're more likely to have an ultrasound of your heart. On these specific vital signs, on these vital signs that are done, you're more likely to have an elevated heart rate. This is something known as sinus tachycardia. You are not more likely to have your eardrums checked to see if they're perforated, however. The better negative control would be a diagnosis that would increase in prevalence with more, say, cardiac imaging in sick ICU patients, but doesn't necessarily happen more as a result of COVID. One such diagnosis that, in talking to Venkmurthy, who's another cardiologist, we were talking about the diagnosis of new valvular calcific stenosis, say, right? Calcific stenosis of valves is something that takes years and years to form and wouldn't happen acutely because of COVID. Since most patients who get admitted to the ICU will get cardiac imaging, a rise in diagnosis of valve disease would indeed suggest more diagnosis of heart attack or heart failure, like these researchers are finding, are really a result simply of more imaging or more testing, as opposed to COVID actually directly causing more heart attacks. Unfortunately, there are things you cannot correct for. And so as lovely as it would be to use massive claims database of millions of people to arrive at a beautiful, simple conclusion, like COVID causes heart disease, the data set on its own may simply not be suited to support, such a claim. It's interesting to look at some of Dr. Ali's prior work. There's another, and this is also in Nature. This was high-dimensional characterization of post-acute sequelae of COVID-19. Again, from the paper, our high-dimensional approach identifies incident sequelae in the respiratory system, as well as several other sequelae that include nervous system and neurocognitive disorders, mental health disorders, metabolic disorders, cardiovascular disorders, GI disorders, malaise, fatigue, musculoskeletal pain, and anemia. So they identified all of those things to be increased at significantly high rates in patients after the post-acute kind of sequelae of COVID was over. So, some, I forget how many months out they looked, but they found all of these things going up. So what exactly are we showing here? And it's interesting that in this particular paper that I'm discussing, in this paper that came out a few weeks ago in Nature, they only limited it to the cardiovascular, cardiovascular and cardiovascular related complications, and showed all these things were up. And then they're saying, oh my goodness, look, COVID is doing something specifically to the heart. But an earlier paper from last year showed that not only was this up, the cardiovascular issues up, but GI disorders, mental health disorders, metabolic disorders, malaise, fatigue, musculoskeletal pain. I mean, is that, why didn't they use those as negative controls per se? So and I'm not entirely sure. If you look at it as a basket of all these things that are now being diagnosed at elevated rates, again, what are we showing? That an illness that puts a lot of people in the hospital results in persistent fatigue and mental health issues even after you've survived the acute traumatic illness? Okay. I don't know how necessarily novel that is, but no, that's an important finding, and we need to support folks who have ended up with more fatigue and more musculoskeletal pain and more issues after surviving kind of the trauma of an acute severe illness. Now, to keep an open mind, of course, we should look to see, okay, you have this data set that's suggesting a signal, correct? We shouldn't ignore it. We shouldn't ignore signals that come out of the VAERS database, and we shouldn't ignore signals that come out of research like this, certainly as cardiologists, to know what to do with. Like, should we be, when we're evaluating people now for cardiac risk should I be asking to see if they've recovered from COVID in the past? Does that put them into a higher risk category? That means that I should image them more or send them for more testing? Those are the questions that face cardiologists when you see kind of a research like what Dr. Ali has shown come out. So we need to look, in order to make this kind of causal connection, I think, as a cardiologist, we need to look to see if there are other data points that also point in the same direction. Notice I didn't say data sets, but data points that suggest COVID could be causally linked to be heart disease. And if there were many other such data points, I probably wouldn't be writing, I wouldn't be making videos on this specific topic. So the one interesting thing to look at also is how we are looking at research that comes out about these issues post-COVID related to what happened after the flu. And it's really interesting to compare the conversations, between COVID and the flu, because what if I told you that the flu has also been historically associated with more cardiovascular complications? Prior to all this thing happening, we all knew that the flu was related, there were a lot more cardiac issues seen in patients that were admitted to the hospital and were severely ill with the flu. Recent research, this is what recent research shows about the flu. Cardiovascular deaths and influenza epidemics, they spike around the same time. Patients are 6 times more likely to experience a heart attack the week after an influenza infection than they are at any point during the year prior to the year after the infection. One study looked at 336,000 hospital admissions for the flu. 11% had a serious cardiac event. 1 in 8 patients admitted to the hospital with influenza experienced a cardiovascular event. 31% of those required intensive care. 7% died as a result. So this is all stuff we knew prior to the COVID pandemic, right? But notice what we did. We did not say that the flu caused, specifically was directly causally linked to heart disease. We didn't come up with some novel mechanism that involved the flu virus attacking the heart. The stress from a severe flu illness is thought to precipitate many of these events, and that's what the conversation was about. We never ever invoked long flu and asked for billions of dollars to study long flu. We did suggest that folks should probably vaccinate themselves from the flu, and if you prevented yourself from getting severely ill, you would prevent yourself from suffering, severe complications, from the flu. One of which included the stress of this causing you to have a heart attack and other, heart-related issues. So why exactly, the conversation seems totally different with COVID. It seems to be that we're trying to say that COVID specifically can cause this tsunami of cardiovascular problems. And then once you establish that link, now suddenly everything comes into play in terms of what we must do to prevent this crazy tsunami of cardiovascular things from happening. It's entirely a possibility, and I don't think we should discount this. And I think what the data actually is more suggestive of is that COVID isn't a novel virus that specifically attacks the heart. It's actually COVID is a bad virus, that it's a novel virus that the vast majority of the population has not seen, and because of that, it will land large numbers of people that into the ICU and can make them critically ill. And once you're in that critically ill state, you can have a lot of cardiovascular complications that may result as a result of it. But you can also have kidney problems as a result of it. The critically ill face multi-organ dysfunction, so it's not just the heart that's being involved. But fine, again, in the theme of trying to look for other data points that suggest COVID is some novel virus that may affect the heart, fine, let's keep an open mind. So I thought, fine, let's evaluate the one mechanism of COVID-mediated heart injury that has been promulgated a fair amount, specifically myocarditis. Again, this nature study does show high rates of COVID myocarditis related to historical controls in the mildly ill, hospitalized, and severely ill. Earlier in the course of the pandemic, viral videos of patients passed out on the streets in China and Iran circulated, and they raised concerns that the high mortality of the virus had something to do with an affinity for the virus to the heart. We knew that SARS-CoV-2 accesses cells through a receptor on the cell surface called the ACE receptor, and the ACE receptor is highly expressed on the surface of heart cells. So there clearly is some plausible mechanism of action for heart injury. Countering these viral videos and the pandemic fear that was being spawned was the fact that this was not the first time humans had encountered the SARS family of viruses. The original SARS pandemic, it's hard to believe that there was an original SARS pandemic, right? But the original SARS pandemic of 2009 that started in Guangdong, China, infected 8,000 people and caused no known myocarditis. The MERS epidemic, this is the Middle East severe respiratory syndrome. This is the epidemic of 2012. Was caused by the MERS-CoV virus, another coronavirus, and there's only one reported case of MRI-confirmed myocarditis that was reported. So again, it doesn't seem like coronaviruses have some specific affinity for the heart, but nonetheless, this is a novel variant that has done things that no other coronavirus has done before in terms of how transmissible it is and how quickly it spreads. So we kind of waited. We waited here in the U.S. For a tsunami of cardiac complications to happen when this virus finally landed on the American shores, but they never arrived. What did happen is that thousands upon thousands of our most vulnerable fellow citizens were stricken with a severe respiratory virus. It's true for any illness that results in a critical ill state that the heart will be affected. It's also true for any illness that results in a critical ill state that the kidneys will be affected. Multi-organ dysfunction is exactly why critical illnesses result in such severe morbidity and mortality. So the question is not, I think it's kind of not a very interesting question about, does a severely ill state result in multiple different organs being damaged? The question really is SARS-CoV-2 have a specific predilection for the heart? The damage to the heart for many cardiologists living through a city with large pandemic was that hearts were being damaged as a result of the critical illness induced by novel coronavirus. Not that the hearts were exploding or that there was some lethal arrhythmia that was resulting in sudden death. Death, unfortunately, came as the lungs of patients severely afflicted were literally chewed up and destroyed by some combination of the virus and the body's immune response to the virus. So it was a surprise to me when I saw news reports of cardiovascular disease plaguing patients months after recovering from COVID. This happened around the fall of 2020 when they were talking about college football and whether to cancel it or not. I clicked on these links that were kind of breathlessly discussing the scope of the problem, and they showed, I came up with a study, and a lot of this was based on a study in recovered patients. COVID recovered patients had found that 78% of survivors had lingering heart disease, of which 60% had myocarditis. Another study, this is a preprint, suggested rates of cardiac disease in recovered healthcare workers of as high as 26%. But both of these studies relied on making a diagnosis of myocarditis primarily using imaging with cardiac magnetic resonance imaging, cardiac MRIs. This was completely unlike how cardiologists had made cardiac diagnosis in the past of myocarditis. Great pains were, in the past, again, generally taken to differentiate myocarditis from secondary injury by making sure there was a reasonable clinical suspicion of myocarditis that had to support the MRI findings. Imaging on its own has always been deemed poorly reliable in making this diagnosis and is not recommended. MRI actually only started to be used to make the diagnosis, I don't want to say reasonably recently, shall we say. In the past, it was a cardiac biopsy with certain histopathologic findings that was used to diagnose the disease. The hallmarks on histopathology for myocarditis were inflammatory infiltrates in the heart adjacent to myocardial necrosis, myocardial cell death. MRI was eventually allowed to be used as a substitute for cardiac biopsy, but only if the clinical findings merit performance of an MRI. So CMR is recommended. Again, these guidelines, CMR's, reasonable guidelines. CMR is recommended for the characterization of myocardial tissue in cases of suspected myocarditis. and just to give you a sense of the type of patients we used to go hunting for myocarditis, a 25-year-old with ST elevation on their EKG, so EKG abnormalities, who had a troponin leak, cardiac enzyme leak, a 29-year-old with chest pain, who was presenting to you with chest pain, who had a troponin that was another cardiac enzyme leak. These cardiac enzymes just don't leak, generally speaking, in normal people that are walking around the street. They do leak much more commonly in patients that are critically ill in the intensive care unit, because of a kind of a supply-demand mismatch. Another 24-year-old patient that would present with syncope and had a cardiac enzyme leak. Notice these are the patients that we were particularly concerned about myocarditis in times past. So this is not. It was never ever clinically suspected because somebody had recovered from a prior viral infection. Like, that was not grounds for doing cardiac MRIs on people. By the way, even in patients that have these cardiac enzyme leaks who are critically ill in the intensive care unit, we're not running around doing cardiac MRIs in those patients because we feel like we have a fair understanding of why these patients are having cardiac enzyme leaks. They're critically ill, and frequently they're elderly. They have underlying coronary disease, and they have areas of mismatch when their blood pressure drops too low or their heart rate gets too high. There's areas of flow mismatch in the heart muscle, and parts of the heart muscle may not get the blood flow it needs for that period of stress, and enzymes will leak in that setting. That's a very different setting than the 24-year-old coming off the street into your ER with chest pain and having an enzyme leak. So in the study from Germany that started some of this COVID heart stuff off, where an impressive 70% of patients who were thought to have lingering heart disease, only 5 out of 100 were found to have had an abnormal troponin. Now, it's possible a bunch of those didn't even get troponins checked, but it's notable that in a disease that really should be marked by myocardial cell necrosis, only 5 out of the 100 had an abnormal troponin. And then they had an abnormal cardiac MRI done, months after they recovered, and that abnormal cardiac MRI on its own is suddenly grounds to say these people had myocarditis or have some lingering heart problems. There are actually other major statistical problems with the study that I went into at length after the study was published. But even without those issues, 95% of the patients in the study that said the majority of recovered patients have lingering heart dysfunction due to myocarditis, again, don't have evidence of myocardial necrosis. That's insane to me. I'll go as far to say that if you're a cardiologist who is quoting this study as proof of COVID causing myocarditis, you either haven't read the study or are incompetent. The study on healthcare workers, right? That was the other study that caused a lot of the 26% of recovered healthcare workers may have some evidence of lingering heart disease. They also used MRIs to rest their diagnosis of myocarditis on. 34% of patients had no symptoms, though. 27% manifested fatigue as their major symptom. Only one patient had an elevated troponin. Only one patient out of the 139 or so folks had an elevated troponin. You simply cannot rely on these studies to comment on whether SARS-CoV-2 is causing primary heart damage. Again, this did not prevent Yanir Baum, a complex system analysis somewhere in New England, to cite these studies. I think he fancies himself as a pandemic expert. He cited these studies in a conversation with Nassim Nicholas Taleb when he noted COVID was making the heart tear with every beat. Here's that amazing clip.
I want to say 2 more things that are going on that we found out just really in the last few weeks. So one is the heart damage, which, as far as the people who are experts, is permanent. And in fact, if you think about it, you tear parts of the heart, it can tear itself apart as it's beating. And what we see is that people several months, and we don't only have several months after they had COVID, then the heart actually becomes a problem. So there's evidence that it may be tearing itself apart, which is horrendous. We don't know how bad it's going to get still.
For what? For about 20% of the population?
It's right now in the heart, the best information is about 50% actually.
What may be slightly more useful is to look actually look for invasion of actual heart tissue by SARS-CoV-2? Like, do we have evidence of that anywhere? An autopsy study that was a literature review of 277 autopsied hearts in patients that died of SARS-CoV-2 did just that. And keep in mind that patients that die from COVID are the sickest group with COVID that exists. If SARS-CoV-2 does invade heart tissue, we surely must see it on autopsy of these patients, right? Some finding of these autopsies demonstrated high rates of pulmonary findings such as diffuse alveolar damage, acute lung injury, but myocarditis was reported in 20 of 277 cases, or only 7% of cases. That's a far cry from the 60 to 70% of cases that these academic imagers found by cardiac MRI. The authors went on to gently admonish their radiology colleagues. Oh, by the way, of those 20 cases, 16 of those cases, the evidence for the histopath diagnosis is actually pretty questionable because the reports just said non-specific inflammatory infiltrates. If you actually read the study, it's highly doubtful. The authors that are from an experienced group are highly doubtful that any of the cases truly showed the hallmark signs of myocarditis that we used to recognize. So the authors went, gently admonish their radiology colleagues and say that the low rates of myocarditis do not indicate that SARS-CoV-2 individuals are not having cardiovascular problems, but rather those complications are likely due to other stressors, such as endothelial cell activation, cytokine storms, electrolyte imbalances. Again, these are all things that happen in critically ill patients. This is a secondary phenomenon where the heart's kind of collateral damage in this process. It'll be incumbent on our colleagues in radiology to better interpret the meaning of cardiac MRI changes and other study data in light of this low incidence of histopathologic myocarditis. So clearly, pathologists telling the radiologist to do better. Look, it's possible that there are other mechanisms of cardiac injury that don't involve what we used to define as myocarditis. But this would involve some type of novel mechanism heretofore not seen at any significant rate related to other viruses. Why would doctors leap to assume this? So when you see a study on cardiovascular complications from COVID that are hunting expeditions, whether it be using big data that relies on diagnostic codes only, from a large claims database, or MRI studies highlighting bright spots of uncertain significance, I would be very loath to conclude this is anything beyond motivated researchers who are hopeful they will have unlimited funding lines to quench a crisis of their own creation.
I hope you liked that video. If you did like it, hit subscribe and keep tuned for other interesting guests that we have coming up on the Upcoding Report. Thanks.